Progressive need for adding meds. Key aspects of progressive COPD medication management include for initial or mild stage, short acting bronchodilators, your SABA or your SAMA, used as an as needed basis for breathlessness or a rescue medication, moderate stage with increased symptoms, transition to long acting bronchodilators, specifically your LABAs. For example, your salmeterol or your LAMAs. Example is your tiotropium, which are preferred for maintenance over single agent therapies. For severe and frequent exacerbations, adding addition of an inhaled corticosteroids to your LABA or SABAs or LAMA to reduce inflammation and exacerbation frequency. Advanced stage, your triple therapy combination of all three, your LABA, LAMA, and your inhaled corticosteroid for maximum symptom control and reduce exacerbation risk. Um, and then we have targeted specialized care. Your phosphodiesterase 4 inhibitors are considered for patients with chronic bronchitis and frequent exacerbations, and your biologics approved as an add on therapy for patients experiencing frequent flare ups, specifically targeting your eosinophilic inflammation. Your eosinophilic count goes up with COPD patients, just like it does with asthma. So, biologic are delivered by IV or an injection. So they would have to go to like a physician's office to get their biologics administered, but it specifically targets the eosinophils to kind of bring them down to lessen their flare ups and their um, exacerbations. And then supportive care is regular influenza and pneumonia vaccines. Um, are essential to prevent exacerbations. So, just kind of by encouraging um, COPD patients to get their vaccines, and especially like on the flu and pneumonia, it kind of gives them that extra little boost and protection to um, for them to catch those infections and then end up in the hospital. So it prevents infections on their part and also hospitalizations that can then put them at risk for catching something else in a hospital. Factors for initiating inhaled corticosteroids for COPD patients are basically to reduce exacerbation frequency in high risk patients, typically in combination with long acting bronchodilators. Your key factors are your high exacerbation rate, so frequent exacerbations, two, greater than two moderate or one hospitalization despite maximal bronchodilator therapy. Your blood eosinophil count is greater than or equal to 300 cells per deciliter, are a strong predictor for responding to the ICS. Asthma, COPD overlap, concomitant diagnosis of asthma. So not only does a patient have asthma, but they also have COPD on top of that. That just kind of worsens um, their severity and is a great candidate to respond to inhaled corticosteroids. Severe airflow limitation, your FEV1 is greater than 50% of predicted. And then once again, your blood eosinophils are between 100 to 300 is considered if other criteria are met.